welcome everybody to the third edition of our Marvelous Medicine series on learning general surgery. It gives me great pleasure to welcome Dr. Dinker, who's Director of the Simulation Center at the Mahatma Gandhi Medical College and Research Institute, Puducherry, and also a Professor of Surgery. As you heard him say, he's a visiting consultant for simulation at many medical colleges in India and abroad. He's also one of my seniors from JIPMER. He did his MBBS and MS from MS General Surgery at JIPMER, and his FRCS from Edinburgh. He's a certified healthcare simulation educator and a Team Steps master trainer, and he's done several certification courses, including from Australia and the Bristol Boston Masterclass. He was previously faculty at JIPMER, and he rose to the level of Professor of Surgery there. After that, he moved on to Malaysia, where he was the Deputy Dean of Clinical Studies at the AIMST Malaysia, and Professor and Head of Department of Surgery at the Malacca Manipal Medical College. Prior to joining his current position, he was in charge of the Department of Simulation of Jurong Heath, Singapore. He's on the editorial board of Advances in Simulation and has written several chapters and articles on simulation in journals as well as books. The Vice President of the Pan Asia Simulation Society in Healthcare and the Founder Secretary of the Singapore Society of Healthcare Simulation. He is the Chairperson of the Technical and Advisory Committees for Simulation of Kerala University of Health Sciences and is a site reviewer for accreditation for SSH. So, Dinker has been active in simulation-based healthcare education for more than 10 years now, and as you heard him say, he also does active clinical practice in surgery. So being involved in both simulation training and active clinical care, I think gives us a really balanced view about simulation and surgery. And I'm really happy to also have Professor Ananthakrishnan with us. Sir has always, been there in all the activities of LGS. I don't think he needs an introduction. However, just a couple of words. He's the Dean of Faculty of Balaji Vidyapeeth. And
not anymore, Vidya.
Okay. Dean of Research as well.
Not anymore.
Okay. So the one thing that cannot change is that he's been the teacher for Dinker, for Patta, for Geeta, for me, for Punendu, and probably 50% of the people who will be joining us today. And he's known for his humor and sharp wit, and I am sure the discussion after Dinker's talk will be very, very interesting. Over to you, Dinker.
Thanks, Vidya, for that introduction. At the outset, I would like to thank Patta, yourself, and generally the learning surgery team. If there are anybody else in that team, I'm not too sure, because you two are the most active, for having given me this opportunity. It's also a great honor for me to have Professor Ananthakrishnan moderating this session. He has been my teacher and mentor right from my MBBS days, and I really look up to him as an example, to emulate as far as surgery and how to live life in general. So can I have you made me a co-host? Can I share my screen?
You can share your screen. Yes, Dinker, you can share your screen.
So then I'll start. It's also nice to see so many old friends in the among the participants here. I can see Ravi Shankar from the US. Geeta is my classmate, of course. Talking to Purnendu. I see that Dr. Padmanabhan is also here. Geeta, that's very nice. Dr. Hadke, I'm sorry, there are so many names that are known that, if I start naming all Nu, Topno, it'll take me forever. So I'll just start my talk now. So I hope all of you can see my screen.
Yes, we can.
Okay, so basically...
You can go to the, yeah, great.
Yeah, my topic for today is simulation training in surgery. And I know that there will be a lot of people in the audience who are not at all familiar with simulation. I saw a brief exchange on Facebook, so I hope that I can clarify some of the doubts of these people. Now, the subject itself is pretty vast. and I don't think I'll be able to, do justice to the entire subject in the time that we have, and it probably is going to become boring as well. So I'm trying to focus in my talk on those aspects of surgical simulation which may not be that familiar to the participants and the surgeons, the faculty, surgical faculty, etc., who are watching this session. So the way I'm going to cover the talk is basically with these questions. What do we mean by simulation? How is simulation training different from traditional training? Does simulation training work? And if we have decided that we want to take up simulation training, how can we change? Some of this is, of course, from established literature, etc., but a lot of what I'm going to talk about today are based on my own thoughts. And I'll welcome questions. Those of you who have any questions can put them in the chat. And if I can request either Vidya or Prof.Ananthakrishnan or Patta to just follow through and bring those questions to my notice at the end, I'd be very grateful. Okay, so if you look at the definition of simulation, basically, I think all of us are fairly familiar with what we mean by simulation. Anybody who has gone to see a movie has been having a simulated experience, because all movies ultimately are simulations, which is they are mimicking reality without actually being real in themselves. Of course, we know some of the Indian movies are far away from reality as possible, but they are still simulations. The main difference, if you like, between simulation in movies and what we talk about as simulation in medicine, or for example, simulation in aviation, is that the simulation that we do in medicine or aviation has got a certain end product, it's got a certain aim, it's got a certain goal. And that goal is essentially we want to learn, we want to improve our skills, problem solving, judgment. Whereas movies, you just go there, you switch off your brain and you just sit there and watch and come. So that is one major difference between movies and the simulation that we are talking about. The other major difference between movies and the simulation that we are talking about is the simulation, when it is used for training, has to be interactive. In other words, you have to interact in some way. This interaction can be in the form of either answering questions on a computer screen. You see a scene and then a number of questions are put to you and you choose your answers. Or it can be an interaction in terms of a physical interaction where actually you have a device like a laparoscopic instrument which you can use to operate on a virtual patient. So that these are the two elements that we have to understand are important as far as simulation and education is concerned. It should have an educational goal, it should have an educational content, and you should be able to interact with the simulation process. These are the two ways in which it differs from, let us say, simulation like movies or television or whatever. So I hope that is clear. So if you see in the definition here, it is an imitation of the real thing, but it has got a purpose, and that is for this practice of skills, problem solving, or judgment. This is just one of the definitions. There are many definitions of simulation, but I thought that this definition would probably make it a little easier to understand what simulation is all about. Now, one of the things, I think all of us are familiar with this. As far as surgery is concerned, simulation can be used in two main areas. One is for training, and which is what we are largely going to be talking about today. And the other is for planning. So now more and more we are using 3D printing to plan out our surgeries. We can print out specific portions of the anatomy of a given patient, his tumor in the liver or in the brain. And we can do a 3D printout of that, have a model on which we can look at the relationship of this tumor to various blood vessels, vital structures in the area, and we can even practice operating on the tumor before we go ahead and operate on the real patient. And there are a number of instances of this that are now being used very, very commonly, especially in facial-maxillary surgery, neurosurgery, major cardiac surgery, transplant, where we can plan our surgery using simulation. I was there, we have an annual conference of simulation here in India, where we get a lot of simulation experts from abroad. And I remember in February this year, we had the conference in Chennai. It was a Pretty Stars conference. And we had the director of simulation from Boston who had come. And he was telling us how they had a complex Siamese twin separation surgery. And the parents had taken these twins to many hospitals in the US, all of whom had said that the surgery is too risky to do and had turned down the surgery. And finally, they ended up in Boston Children's Hospital, and there they decided to take up the challenge. And for almost a few months, the surgeons were practicing with simulated models, which were printed, where 3D printing was done. And after having done that, they became familiar with the anatomy, they became familiar with the process, with the teamwork, and then they went ahead and did the actual operation. And they were surprised to find that instead of an anticipated 24 hours for the surgery, they took 7 hours, and the twins were up and about next day itself off ventilator. So that is what planning in simulation can do for you. But of course, I'm not, because of the, again, paucity of time, I'm not going to go into more detail for planning, but I'll be concentrating more on training. Now, all of us are aware of nowadays, this is, more and more important, safety in cars, safety in automobiles. And it's very important to have these crash tests on the basis of which automobiles are graded as safe or not safe. And this is an example of a crash test being done in America with dummies in the car, and then they see what sort of injuries these dummies have sustained after a direct head-on collision or a side collision, etc. And this is how we do the crash test in India. And I think all of you will agree that the US method is probably better than the way we do it in India. Unfortunately, we may laugh at this thinking that, but it's not a joke. It is actually happening in reality. And in medicine as well, in surgery or any other discipline of medicine, we are exactly putting our trainees directly into the field, making them jump in at the deep end and saying, you swim or you sink. So it's probably in the present day scenario, it's not such a good idea to do that. Now, so what why do we need simulation? We know that with the number of medical colleges that are mushrooming up all over the country, in each college, we are getting more and more medical students coming in. And now on top of all that, we are having this big blow of COVID, which has further, created a famine as far as elective patient surgery is concerned in most of the teaching hospitals. So all that means that we have a reduced chance for our trainees to practice surgery or to do surgery. And also now more and more by regulation, at least not so, as far as I know, it's not yet in India, but I'm sure it will come, where they're supposed, it's mandated that they do a certain number of procedures before they go on to independent practice. And therefore, simulation-based training is the ideal modality to fill this gap between working on real patients and not having any practice at all. Okay, so what are the how does traditional training take place? I just want to show you how simulation training will be different from traditional training. So this is what we are now used to. In all of us have undergone training, and this is the way we have undergone training. So we have supervised practice on patients, where in first year we are doing minor operations. Our second year postgraduate is helping us do those surgeries. As we get more and more senior, we get more and more senior assistants. Our skill levels keep increasing. And ultimately, as we are coming into final year of post-graduation, we start practicing, we start doing some independent practice on minor operations. We can do some hernias, maybe even DU perforation. When I was training, we were doing truncal vagotomies at this stage. And it is a well laid out method of training. And finally, when you graduate, you finish your master's, and you suddenly become, an assistant professor or a senior resident, you start getting a jump in responsibilities, and a lot more of your surgeries then become unsupervised. The problem with this is that at every step of the way, there are chances of errors. And we may say that we are closely supervising our students all the time, and therefore the chances of errors are minimized. But we know that that is far from the truth. We do not have the time to all the time look over their shoulders when they are doing surgery, especially in emergencies. They are largely left to their own devices. And so errors can creep in. And in the past, we used to justify this by saying it's okay, by making mistakes only we can learn. While that statement remains true, it is not true that we need to make those mistakes on the patients. It's much better to make those mistakes on a simulator so that we are better prepared when we face actual patients, and the error chance would be less. So this traditional training is in contrast to simulation-based training, where you start off by doing a supervised practice on simulators for surgeries and for skills. One thing we must understand, and all of us who have done surgery for some time will also know, that you do not need to be a master of every surgery in the book. What you need to be a master of is certain basic surgical skills, the skills of dissection, the skills of cutting, the skills of suturing, the skills of finding the planes, and in laparoscopy, hand-eye coordination. Once you have these basic skills, it becomes easy for you to start doing more and more complex surgeries. So the idea of supervised practice on simulators is to acquire these basic skills. And what is important is that you need to be mandated to achieve a suitable skill level before you can practice on patients, which means that you are allowed to practice on patients only when your guide or your facilitator deems you fit enough in skill on the simulator to be able to do some supervised practice on patients. And as your operations become more complex, you go back to the simulator, practice these more complex steps, and again go back to the practice on patients. And so this is like a upward going spiral, which becomes more and more complex operations as you go up. And eventually you break out of that spiral and you start doing independently with increased responsibilities. So this is the way simulation training will happen for surgery. And in this way, it is hoped that the errors that happen in the clinical, in the operation room or in dealing with real patients gets minimized. Of course, it can never be totally eliminated, but we hope that this will minimize the errors, number one. And number two, the training becomes more systematic and we ensure that all our postgraduates or residents start getting a more uniform exposure to cases and to surgeries. Now, everybody equates simulation to technology. But what is important to remember, we get fascinated by technology. Any new phone that comes, any new gadget that comes, we want to have it and we play around with it. And ultimately, we just use only 10% of the total capabilities of that particular device. So technology is only the means. It is not really the end. And that is one thing we have to keep in mind. A simulator may look very nice. You may be wowed by the fact that you can actually when you cut into the liver, but that's not what it is there for. You have to focus, like all medical education, here also you have to focus on learning outcomes, and your simulation should be tailored towards the learning outcomes. So it is not that you use simulation according to the tools that you have. Rather, you should have the tools according to the learning outcomes that you want to achieve. And a very important statement that was made by James McGee et al. Was that technology should make learning better, not just different. We all know, we go for feedback from students and they will be very happy. You let them play around with the simulator. They'll be very, very happy and give a very positive feedback. But that feedback does not necessarily mean that learning takes place. We need to have objective evidence of learning. That is something that is important to remember. Now, as far as surgery is concerned, I just want to highlight on these simulator types. So we have standardized patients. These are actual trained actors who behave like patients, and they are, and they are sometimes ironically called as warm simulators to differentiate them from the cold simulators, which are the computer-controlled mannequins. Then we have the various types of task trainers, and we have hybrid models. When we say hybrid models, we basically mean it's a mixture of two different types of simulation. So it could be, for example, a physical model with a superimposed augmented reality or a virtual reality. Or it could be something as simple as, we have these small pads on which you can practice suturing. So you could strap that pad on to the arm of an actual person, and that would become a hybrid model where the person can react with ouch or, refuse to give consent or act difficult or whatever way we want to challenge the learner. So these are examples of hybrid models. So I'll just briefly go through these different types of simulators. Now, the standardized patient is used, we are using it on our hospital also. We have a good standardized patient program for communication skills and also for, breaking bad news, informed consent, etc. And we are using them for our OSCEs. All of you must be familiar with that process. And to some extent now, because of COVID, we have started using them for examination as well, where even though you cannot pick up findings, you can still, you are able to look at the technique of examination. Having said that, even at the time when I was a postgraduate, we had these chronic patients who had lumps or in medicine, especially chronic heart murmurs, who are coming year after year for examination, and they knew better than you what these murmurs were. And if you bribed them enough, they would tell you their entire diagnosis. So the standardized patient concept is nothing new. Then we have the task trainers. I'm not going to spend too much time on the task trainers because I think most of us will be to some extent familiar with these. So these task trainers are either physical simulators or virtual reality simulators or hybrid simulators. So they vary in terms of the complexity of the of the task trainer. Now, if you look at the physical simulators, we are again familiar with animal and cadaveric specimens. So we know that so many workshops are held all over the country for with cadavers, and usually these are fresh frozen cadavers which are then thawed and then used for practice of various surgical skills. Similarly, we have animal models. We know that all of us have experienced the use of pigs for laparoscopic surgery practice. We use even parts of animal, like using a chicken feet for suturing practice. In our center, we do the pediatric advanced life support course where we bring chicken thighs in for bone marrow puncture practice for, so animal and cadaveric specimens are well known. There are a lot of advantages and disadvantages to using them. I'm not going to go into the details. I suppose in other countries, it's difficult to get cadavers. Animals, there are a lot of regulations now which prevent you from using animals freely. And similarly, when you use cadavers or animals, you miss out on the important component of bleeding, which is what makes surgeries so difficult. If it was not for bleeding, I think most surgery would be very, very easy. So there are advantages and disadvantages. I won't go into more details on that. Box trainers, again, we are familiar with this. So these are used for laparoscopic surgery, and you have a camera and you have the laparoscopic instruments, and you use these box trainers to teach students on various simple tasks like transferring beads from one container to the other, or cutting a circle in a piece of glove, or doing some basic suturing, etc. What is important is that these box trainers are used for in the curriculum to develop laparoscopic skills, and there is enough evidence to show that the skills that are learned on these box trainers can actually be translated into clinical skills in the actual operation theater. Then we have the various suturing and knot tying kits, which again we use for our interns, for our first year postgraduates to teach them how to suture and how to tie knots. Now, coming to virtual reality simulators, I'll spend a little more time on this because this is one area where people may not be so familiar. So they may be computer screen based, or they can be fully immersive. And it's so immersive, you have two types of immersion. One is virtual reality, the other is augmented reality. The computer screen based simulators are simulators where you're looking at the patient anatomy on a computer screen, and you are having instruments with which you are operating on the patient, and you are getting a feedback from that instrument, what is known as haptic feedback. That means when you touch the liver, when you're doing a laparoscopic cholecystectomy, you'll feel the resistance as though there is actually a liver there, whereas in reality, there is no such thing. So these are the computer screen-based virtual reality simulators. The immersive virtual reality simulators is where you wear a headset and you are immersed in an entirely new world, a totally artificial world, but where you can look around, you can interact with the patient, you can also interact with other colleagues like your operating team around you. And I'll show you an example of that shortly. Augmented reality is where you are superimposing computer generated reality or virtual reality on something that is real. You may be familiar with Google glasses, for example, when you wear them, and you can see, let's say, when you're traveling, you can see the map scrolling before your eyes as you're driving. So you can see out of your car. At the same time, you can see the map, etc. And when you're operating, similarly, you may be able to see, if you want to see instructions, you can see it, while you're still able to see the patient. So it's something like a heads-up display. So this is augmented reality. Virtual reality, on the other hand, whatever you're seeing is not at all real. So that is the essential difference between virtual reality and augmented reality. Now, so as I was talking about the screen-based virtual reality trainers, this is an example of one of the company's products. And I was talking about the haptic feedback. And what is important is that these record a series of metrics from the student when he's operating. how much time he took, how many times he damaged the surrounding structures, how much was the amount of blood loss that he caused, how many times, what is the movement of the surgical instrument tip, how much did it move. All these haptics, or these, sorry, all these metrics are recorded. And then at the end of the procedure, the student can check how well they did. And as a facilitator, the important thing is you can set certain benchmarks or standards which the student needs to achieve before he can go on to operate on real patients. So haptic feedback I've talked about is a sense of tissue resistance, which one of the problems with these simulators is, because if you want to make it perfect, they require a huge amount of computing power. So they sacrifice reality to some extent in order to make them more practical to use, more feasible to buy. And so realism is sacrificed for practicality. So the sense of tissue resistance, for example, is usually felt only at the tip of the instrument. So sometimes if you go out of your operating field, let's say you're doing a laparoscopic cholecystectomy and you go and touch somewhere far away like the fundus of the stomach, you may find that the instrument just goes through the fundus of the stomach, because the fundus of the stomach is not modeled into the system. Whereas if you touch the area around the gallbladder like the liver, etc., you will feel that resistance because that is modeled in. And that is done deliberately in order to make it more practical, as opposed to something that requires a huge amount of computing power and consequently becomes more expensive. It also requires tissue deformation. When you pull on a structure, you should see it becoming thinner, you should see it stretching out. And if you pull on it too hard, you should see the structure tear, maybe it's cause some bleeding, etc. So when we talk about immersion, we are talking about virtual reality. So the user should feel that he's actually present within that environment. And what is important is you should be able to navigate through that space. In other words, if you move around in that space, you will be able to see the patient, for example, from different angles, and you'll be able to see the anatomy of the patient from different angles, just as though it was a real patient lying in front of you and you want to switch sides while operating to see something from a better angle. You should be able to do it in the virtual reality environment, and you will see that different angle. And of course, the user should be able to interact with the instruments, with the patient, with your other colleagues you are seeing. You should be able to talk to them and they should talk back to you. So hybrid simulators are, as I said, where you can have two combinations of different types of simulation modalities. So here you are seeing an example of an arthroscopy simulator. So you have a model of a knee, but inside that model of the knee, there are no real bones, there are no real cartilage or any other structures. What you're seeing is entirely computer generated, but because they have modeled in just the femur and the tibia, when you touch it, you get that feeling as though you're hitting real bone, because you're actually hitting a physical structure. But all the other anatomy of the knee is only modeled. And so this is an example of a hybrid simulator. Okay, so this is showing you somebody who's wearing the, I think this is the Oculus Rift headset, and they are practicing on a virtual patient. There's no physical patient here. They are practicing a knee, drilling into the knee, I think probably for knee replacement. I'm not too sure because I'm not an orthopedic surgeon. And you see what they are using are two devices which allow them to interact with the virtual environment. And these two devices, though they are not shaped nothing like a surgical instrument, when you see the thing through the virtual reality, it looks like a surgical instrument, and using these devices, you can actually operate the surgical instrument. So this is showing you immersive simulation. Now, we have all heard of 3 degrees of freedom, and now we have the virtual reality, which gives us 6 degrees of freedom. What do we mean by that? The 3 degrees of freedom are given by simple virtual reality devices like your, Samsung Gear. If you remember, Samsung came out with the Gear device where you put the Samsung phone into the device, put it on your head, and then you can see as though you're virtually immersed in that environment. Similarly, your Google Cardboard, which is a very simple virtual reality device made out of cardboard, very cheap to buy. And even in India, a lot of medical work has been done using cardboard. This gives you just 3 degrees of freedom. What it means is when you turn your head from side to side, or tilt your head, or nod your head, you will be able to see the image moving accordingly, as though you were really looking at it, looking at that image while you were doing these actions. But with the higher end virtual reality devices like the Oculus Rift or the HTC Vive, the example of which you saw in the previous slide, where you wear the headset, you have 6 degrees of freedom. What it means is that you can physically move through that space. So for example, you can move your head forward or you can move your head back. You can walk forward, you can walk back, you can walk sideways, or you can squat and get up, and the entire picture will change according to what you're doing. So this is the 6 degrees of freedom virtual headsets, and that is what we are all gravitating towards when we are talking about using virtual reality in all fields, including in surgical training. Okay, so this, I'll just play a small video. This is of course from a commercial, from a company video, but I thought it gives you an idea of what the virtual reality environment looks like. So let me just, give me a second. Okay, so that was a short video just to show you what a virtual reality surgical simulator looks like with an operation suite, etc. I had the privilege recently of being a PhD examiner for a simulation-based thesis in Delft University in Netherlands, and the thesis was all about gaining surgical laparoscopic skills through simulation. And what was mentioned in the thesis, which I found very interesting, was that when we are doing simulation for learning surgical skills, it is, if you like, a very sterile environment without distractions, without the usual sort of tensions and other issues that we face when we are operating in a real OR. One of the biggest advantages to me personally, I feel, is that we don't have anesthetists when we are operating in the virtual environment. I hope there are no anesthetists in the audience. However, if you want to get the real experience, you must have those distractions. You must
Dinker,
have
when the Vidya is right in front of you,
I know, sorry, I forgot about you.
be careful.
So when you're, you must have those distractions, because that makes your training more realistic. You must have a mobile phone ringing in the background. You must have somebody being annoying. You must have, an assistant who is not retracting properly. Now, these things, we are not there yet, but a lot of these distractions have been built into the virtual environment so that it makes the training more realistic, and they find that the skill gaining is also much better. Now, this is an example of a physical simulator. It's not a virtual simulator. It's actually a physical simulator, which is a full body surgical simulator known as a cut suit. And this is a wearable simulator. In other words, a real person or a mannequin, it can wear this simulator, and you can do surgical procedures ranging from putting in a chest tube, or doing a cricothyroidotomy, or even doing a full-fledged laparotomy on a human being who is actually wearing this simulator. Of course, it's got a totally protective plate and all underneath. You don't want to stab the person who's under that simulator, but it gives you a pretty, if it's not 100% realistic, at least 60 to 70%, it can approach realism, because you have a real patient who's there wearing that simulator. And I'll just show you again a small video which shows you this cut suit.
The cut suit enables medics, corpsmen, and combat lifesavers to safely perform real medical procedures with a live human. The cut suit is the only simulator that can be used to treat a simulated casualty from the point of wounding, to treatment en route, to the shock trauma team and surgical intervention hyper-realistically. The Tactical Combat Casualty Care, or TCCC version of the cut suit, is the most realistic way to simulate treatment for the 3 most preventable causes of death on the battlefield: hemorrhage control, tension pneumothorax or sucking chest wound, and airway management. The surgical version of the cut suit allows for surgical chest tube thoracotomy, suturing and stapling of skin in all locations, Foley catheterization, bladder tap, laparotomy, and intra-abdominal exploration and hemorrhage control of gross organ structures. The cut suit is the most realistic way to simulate the look, feel, and smell effects of severe traumatic events on a live human.
We got blood. We got suction up. You guys got suction or what? Slap, slap, slap. I got a bleeding iliac vessel. So I got my hand on the vessel that's bleeding. Here's another. Here's one.
Another one up?
Here it is. Okay, use that. I think we need to put a clamp on it. Let's have some vessel clamps. So let's look at this other iliac, okay? There's your peritoneal stuff. Good. All right, I think the bleeding stopped. There's no blood left. They go to, I mean, this needs to go away.
Clamps and bars? I need another one of these.
You take that and that. Yeah, we do. So that was an example of the cut suit in action, and you can see that gives you a fairly realistic experience. Now we come to the next question after having seen the different types of simulators and getting some idea of these simulators. Do they actually work? And I think now it's beyond doubt. It has been proven beyond doubt that simulation works, whether it be in the field of surgery or in any other field of medicine. And there are lots and lots of articles. This one, for example, using VR simulation, showing that it improved operating performance of residents during laparoscopic cholecystectomy. Another article which talks about endoscopic training. And it shows that VR simulation helps trainees with either limited or no prior endoscopic training. It helps them to achieve skill. And this is also a statement which says that simulation-based training results in skill transfer to the operating setting. And in fact, there was an article which showed that this works not only with trainees, but in even well-experienced surgeons. When they practice skills on the simulator, it results in an improvement of their skills in the operation theater. So the days have come now where simulators are not just meant for use by trainees, but even experienced surgeons can use them. And I'm sure all of those of you who have worked with robotics know that the Da Vinci system comes with its own simulator, and they mandate that you must use the simulator first before you start working with a robot. So it has come in a big way as far as robotics is concerned. And I think it is time that it came in a big way in all other aspects of surgery. Now, I just want to pause here for reflection. We were talking so far about technical skills, which is what concerns all of us as surgeons the most, which I think needs to change now. And I think we need to change our focus from technical skills to non-technical skills. Look at some of these things which happen day in and day out. And I have picked up some from real events that have happened. I'm not going to go into the details, but we are all familiar with wrong side surgery happening even today so often. Even if you say, for example, you're talking about accidentally cutting a major vessel during surgery. What do you think is the common factor between these two? It's really, you may think that at least cutting a major vessel during surgery is because of technical reasons. But if you really go deeper into it, that's not true. In both of these situations, we have lost what we call situational awareness. We are not sure about what we are doing because we are not sure about the situation. Wrong side surgery is because somebody has labeled it wrong. In fact, Dr. Krishnamurti, I don't know if he's in the audience, he runs patient safety courses, and he had sent me some examples of patient safety issues. And one of them was wrong side surgery because the intern marked the side wrong, and the surgeon did not cross-check the mark on the side. And then on top of that, when the WHO checklist was read, you tend to answer mechanically, yes, 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 without really going through the checklist properly. So when they said right side being operated on, he nodded to actually he was standing on the left side and operating on the left side. And it ended up with a wrong side surgery. So that was a clear cut. There was nothing technical, there was no question of the surgeon's technical skills, but the issue was with the non-technical skills. Similarly, accidentally cutting a major vessel during surgery, we can argue that it is a technical problem, but most of the time, especially with more experienced surgeons, It is a situational awareness problem is what I firmly believe. Because of the distorted anatomy, you are not anticipating that that particular blood vessel is not in its usual anatomical position. Or you have become a little overconfident. I know all of us immediately when we finish our masters and we become senior residents, that is a phase of our career when we have the maximum confidence. We believe we are gods and that we cannot do any wrong. And of course, we are brought down to earth pretty quickly once we start getting complications. So these are non-technical issues with either losing situational awareness of the distorted anatomy or having an overwhelming belief in oneself, which is part of non-technical skills and not technical skills. So it has been shown that more than 70 to 80% of medical errors happen because of problems with non-technical skills rather than technical skills. This is the statistics from the US, and this is from the 2013 statistics. It shows that the number of deaths due to medical errors in the US equals 800 passenger flights crashing every year, which means 2 flights or more than 2 flights crashing every day. That is the degree to which we would never tolerate or we would never step into a plane if that was the frequency with which planes were crashing. And yet we have no qualms about going into hospital to undergo surgery. It is equivalent of us stepping into a plane where 2 crashes are happening every day. I don't know how many of you have gone bungee jumping, but in terms of risk, bungee jumping is classified as to be as risky as going into hospital for a procedure is. So it shows you that going into hospital is quite risky. It's fraught with risk, and a lot of this risk can be mitigated and in fact reduced if we are aware of human factors which cause these risks. What are these human factors? This is also known as crisis resource management. We all work together as teams. Unfortunately, at no time during our MBBS or even during our post-graduation do we make a conscious effort to teach people how to work together as teams. They just learn it by experience. They've never worked with a nurse before they come into the operation theater and they scrub up for the first time. They have never worked with a theater attendant. And all these people are key cogs in the machine. And the problem with the machine, a chain is only as weak as its weakest link. Anywhere where any of these links can create a problem, and when you're not familiar with each other, those problems can become much more acute. So you have to be familiar with your roles in the team, who's the leader, what are the roles of the team members, the communications. We Indians are very good at communicating in our personal lives, in our daily lives. In fact, we just can't stop talking, and I'm a prime example of that. But we are very poor at communicating in the operating theater, in the medical field, when we have to really talk about a patient and when we hand over, etc. Somebody's trying to communicate. So feedback loop, we keep emphasizing it again and again, but how many of us really use it? And it has been shown to save so many lives so often. Global assessment, another word for situational awareness. You must be aware of everything that's going on around you. You must be aware of what's going on with the patient, what your team members are doing, what's going on the monitor. And it's very easy to lose focus and just focus on one particular thing. I have seen people who are looking at a monitor and they're only looking at the heart rate, and they're missing the fact that just below that, the saturation value has gone down to 80%. And you will think, how can somebody miss it? But it's so easy to miss when you're not, when you're focused so much on one thing that you lose your situational awareness. Any one of us who has got into an accident will know, most of the time, the cause of that accident is our losing situational awareness, because we get concentrated on any one thing, and before we know what's happening out of the blue, either we have hit somebody or somebody has hit us. Mutual support is essential for the team. All team members have to be on the same page. Unfortunately, this is another thing we don't follow. When we have a team, the junior most member of the team is usually left to fend for himself or herself. Interns are not considered. There is sort of one level below human, if you like, So the order of hierarchy comes with the professor, the senior consultant, the junior consultant, the postgraduates, the nurses, then the theater attendants, and after that, maybe the intern. So this should change. Everybody is equal in the team. Everybody has got equal rights to speak up. And sometimes the interns can give you valuable inputs which other team members may not be able to give you, simply because they are not directly immersed in the management of the patient, and they have a better global outlook. So it's important for us, no matter how senior we become, to listen to the other team members, keep our minds open, listen to their suggestions. You may not agree with those suggestions, but you don't, cut them off before they can make a suggestion. And we surgeons, unfortunately, have a habit of doing that. Resources, we must make use of all available resources. It's very important, and it's more important also that you be familiar with all the resources that you are using. Otherwise, nowadays technology is improving so much, you are getting newer and newer instruments, and we have a tendency to get the latest in the market and start using it before we even know how to use it properly, and that is a harbinger for disaster. So how do we impart all these non-technical skills? We never went through them. We learned it the hard way, but that does not mean that our trainees also need to learn it the hard way. Traditional training systems, all of you will agree, do not address this issue. And therefore, I believe firmly that simulation is the way you can do that. And how do you use simulation? We have the last aspect of simulation that I talked to you about earlier, which is the full body computer controlled mannequins. And these, unfortunately, they are very expensive, and they are used as task trainers. How to put in an endotracheal tube, how to put in a chest tube, how to start an IV. But these are not task trainers. They are much more than task trainers. We use them for team training. People work together as teams to manage a surgical or a medical crisis on these simulators. In the course of managing that crisis, they may need to do certain procedures like putting in a tube or starting an IV, but the idea is not to teach them how to do that. The idea is for them to take the decisions for decision making and proper teamwork, communication, etc. And some of you may be familiar with the non-technical skills for surgeons, which is abbreviated as NOTS, which was started by the University of Aberdeen, and all UK trainees have to compulsorily go through these courses now. And they talk essentially of situational awareness, decision making, communication and teamwork, and leadership. You can Google it, and the handbook for NOTS is free download. You can download it. It's a very valuable resource, and I think you should start implementing this with your own trainees as well. This gives you some example of the sort of moulage, the makeup that we can do with these mannequins to make them look much more realistic. And if you study this a little bit, it's not very difficult to make them up to look realistic. There are lots of programs where we are using simulation now as a routine basis. We are all familiar with the advanced trauma life support. Earlier, we were using animals, we were using cadavers. Now, it has been accepted that you can use simulators in the ATLS courses. Fundamentals of laparoscopic surgery in the US, it's an essential course that has to be completed by all trainees. And there are certain clear-cut skills that they have to get. Only then they are allowed to go into the operating theater to handle laparoscopic surgery in patients. You may or may not have heard of the care of the critically ill surgical patient, the so-called CRISP course, which is from the Royal College of England. And this again is compulsory for all surgical trainees to undergo. I am a faculty for this course, and it's essentially it's a course which helps surgical trainees on the ward. When a crisis happens, you are the junior most, you in the middle of the night, nobody else to call for help. How do you manage? You have a patient who's collapsed, you have a post-operative patient who's hypoxic or hypotensive. How do you approach such a patient? How do you reach a decision, and how do you stabilize the patient before escalating the issue? So all these courses use simulation, and almost all training programs worldwide now are mandating simulation as part of their surgical training. Unfortunately, in India, we are still lagging behind quite a lot in this. Lots of advantages of simulation. I won't go into all the details, but it allows you to practice things repeatedly. You want to do, you can do laparoscopic cholecystectomy 100 times in that virtual reality simulator to improve your skills. You can practice rare situations, which you don't face very often. And it allows practice of critical situations, which I already talked about a little earlier. So there's no doubt now that surgical simulation works. And the American College of Surgeons has identified potential for simulation techniques, which are the areas in which it can make an impact. So one is on patient safety, and this is a critical buzzword nowadays, patient safety. Even for surgeons who are coming back after a layoff to refresh their techniques, to correct case mix inequalities. So rather than training being just serendipitous, you can make sure that everybody gets an equal exposure to different types of patients. And if you are developing a new procedure or a new device, you can test this in the simulated environment before going on to the real patient. Having said all this, we know that most of us are not using simulation in our day-to-day training. How can we change? If we want to change, the first thing is we need to accept that there is a need to change. You need to believe that this is something that will help me, that will help my trainees to become better surgeons. Once you get to that stage, then you will automatically get the interest to take the next steps in simulation. Unfortunately, most of us stop at that first level itself, and therefore simulation does not progress beyond. The best way I have personally found for you to get belief in simulation is to experience simulation. So when I go and conduct training in different places, Dr. Geetanjali is here. I had conducted a similar program in AIMS Bhubaneswar also. I make the faculty members go through a simulation experience as participants. Initially, a lot of them are skeptical and they say, what can this, only a dummy, what can it teach me? I've already got so many years of experience. But when they go through a stressful simulation experience, they come back shaking and they say, my God, I did not believe that I was capable of making such mistakes. If I can make such mistakes, what about my trainees? So I would strongly encourage you, if you have an opportunity, attend a simulation session, experience simulation for yourself. Then as a facilitator, simulation is a totally different ball game as compared to most of the other ways of teaching that we are so used to, whether it be bedside teaching, small group teaching, classroom lecturing. Simulation pedagogy is a little different. It requires different skill set and we need to learn that. It is not difficult, but it requires time and it requires a certain amount of effort from your side, but it is doable. But you need to have the will to do that. After all that, incorporate it into your training program in forms of a curriculum. If you don't put it in the curriculum, it's not going to happen. It will be just, sometimes you will occasionally do it, but it will not happen on a regular basis. And finally, as you go through, just like in any other medical education modality, look at your results, revise it, refine it, and then, improve upon it. Thank you all so much.
Thank you, Dinker. Thank you very much. That was very informative and exhaustive and beautiful talk on simulations, and nothing less, of course, is expected from you from your long years in this field. Now I'd request the participants to kindly put up their questions in the chat and I'll raise them with Dinker one by one, as many or all if possible. But while we're waiting for them to put up their questions, I just start the ball rolling by making my own comments if Dinker permits. Now the pros of simulations are well known and Dinker has enumerated many of them, and they are admirable for the purpose that they are meant for. And also from the pedagogic point of view, as a teacher, it makes learning much more interesting, experience based, which is good for lasting retention. It makes possible, as Dinker said, for rare events training. Dinker will remember rare events like disaster management. We used to train with simple cardboard-based simulators in JIPMER, particularly where team training is a very important aspect. But from the point of view of learning, the greatest advantage, of course, is the opportunity to train and retrain, to analyze performance and give a feedback, because that is nothing better than that for promoting learning in students of any level of seniority. But what we often don't discuss are the cons of simulation. And I would like to draw all of your attention to an excellent paper which came out from Kerala by Divya Krishnan and her colleagues, published in the International Journal of Medical and Health Research just 3 years ago. It's a review of the pros and cons. And I would like to start the discussion going by raising some of these cons, and then I have two specific cons of my own, which I will add at the end, or maybe I'll start with that. The simulation is good as a complement to teaching clinical skills in the real life situation. But what is now happening, and it's not only the number of students, but what's happening in medical education is it is being used not as a supplement, but as a replacement for patient-based training. And thereby we miss many of the skills that can only be learned by the bedside, particularly attitude and communication. And almost 100% of the disputes these days between healthcare providers and the patients and relatives is based on communication mishaps. And those of you who are in private setups like Purnendu and others will realize how important communication is there, and whatever be the nature of standardized patients, if one uses simulation as a substitute and not as a complement, we are going to produce not only surgeons, but every type of specialist who is going to lack in attitude and communication. And therefore, one has to understand and impress upon the administrators and others who try to make up for lack of patience by substituting them with simulation so that they can go on continuing with whatever they do. That's a huge issue in medical education now. But coming back to the paper from Divya, Dinker, she has raised some very interesting disadvantages. And there are, of course, many other papers on disadvantages on simulation, and you, I am sure, as a trainer, you would have read those, the many listed disadvantages of simulations. I'm not anti-simulation, but I just want to raise the other side of the question so that we have a complete view of the picture. One is and I am quoting now Divya and it's not my own, incomplete mimicking of human systems leads to deficiency in concept understanding, however be the level of fidelity. And therefore, when you encounter, and there are many people who have done nothing but that before they encounter real patients, they find themselves a little out of their depth, as I think your daughter will find when she does her scuba diving. So, and the second is, there are many studies which say that when learning is only simulation based, it leaves a lot of deficiencies. I've already mentioned attitude, because when you know you are working on a simulator and you know that you are being observed, the Hawthorne effect comes and you perform better than what you normally do when nobody is watching. And therefore, your scores may be good. Purnendu is one of the classical examples of that. So nice to see many of them like Hadke and Debu and all that, whom I have not seen for years together. Or it becomes cavalier because you know that patient safety is not involved, and therefore you become a little careless. The cost, time, and the infrastructure, of course, you have mentioned. But my main point, which Divya has mentioned in passing, is simulation-based training is not learner-specific. Just like we can tailor our teaching to students in real life to be learner-specific, like we do with the Cobalt program in Mahatma Gandhi, you know. And therefore, all learners they may get more chances, but all of them are initially treated as the same. And therefore, that opportunity to differentiate between the learning curves is not often there, because the time available for providing practice is also limited. These are some of the issues that I would like you to comment, and then I will read the questions from the chat box.
So one of the first things I've learned, sir, is the next time I give a talk like this, I'm not going to have you as moderator.
No, I have no choice. You know, I told you, I've always named Vidya a terrorist, and she gives me no choice. She just sends me a mail, you are moderating, and therefore I am moderating. I would have very much preferred to not to be so formally dressed and sit and listen to you, but just as you have no choice, I have no choice.
It's Vidya to blame. I'll remember that. As always, it's an anesthetist who is to blame for all problems.
Absolutely. That's the best thing that I heard you say, that the operating room will be much better if anesthetists are not around.
So they were sorry about that.
Yeah, Debu's already objected to that.
Yeah. Okay. So coming back, that's a very interesting observation, and an observation that I agree with in terms of the fact that simulation can never substitute for actual patient care. And I don't think any simulationist worth his salt can argue that you can train somebody entirely using simulation without any patient care at all. I think that is a totally unrealistic way of looking at it. We have to understand that just like so many other modalities of teaching learning, simulation is simply another modality of teaching learning, which adds an extra, you know, it adds to the armamentarium of teaching learning for the facilitator. So you can use this where it is appropriate. So,
Unfortunately, that message is not often given in talks on simulation.
Very true.
And the regulators close their eyes to it, and they prescribe simulators in medical colleges, and they are willing to overlook the shortage of patients and increase the seats, because you know nowadays the government of Tamil Nadu says we have 5,000 more seats, as if it is something extraordinarily proud achievement, and they are responsible for that. Actually, it's the management and the interaction between the management and the MCI which brings about this. But that message should go, I feel. That
I would say, as far as the regulators are concerned, I will say yes and no. Yes, in terms of the fact that the regulators are mandating simulation in medical education without really understanding what it is about.
Correct.
And therefore, it is a very superficial way in which they are addressing the issue. And no, in the sense that I strongly believe that they should have done much more in advocating simulation in a proper way in the medical education curriculum, in such a way that it is integrated with our other modalities.
Absolutely.
Right now, to me, it appears that simulation is just that they're tacking it on because it is a fashionable thing to do, without really grasping how it will integrate with the other ways in which we are teaching our undergraduate, or for that matter, our postgraduate medical students. And I think that has to change. So we have to understand that it is a supplement rather than a substitute for actual patient care. Regarding some of the other issues that you brought up, I believe that as far as communication skills are concerned, simulation lends itself very well to teaching communication skills through the use of standardized patients, etc. One of the reasons I believe we are poor in communication is because in the majority of medical colleges today, we are not teaching communication skills in a good way to our undergraduate students. In JIPMER, we were lucky, we had the NTTC and we learned communication skills very early on, which, barring a few exceptions like Pune, made us very poor private practitioners, but it made us, at least better communicators with our patients. But that is not the case with the majority of medical colleges. If you look at the training, medical training abroad in most of the other developed countries, etc., you would agree that if you have seen the medical students there, they are much better communicators. And the reason why they're better communicators is because they have had interaction in the simulated environment with standardized patients, and they have been given a chance to improve. They've been given feedback, as you rightly pointed out, that's very important. And then they are made to interact with real patients, and those interactions also are then reviewed, and so they undergo a constant cycle of improvement. So I do believe that simulation is a good way of teaching communication skill so that it improves patient-doctor interaction.
I am a great advocate of standardized patients, you know that. But the problem with standardized patients are that they are too standardized, and in real life, patients are not standardized at all.
Which is why,
and therefore, every patient has a different response
Yeah.
to the same situation, a different way of asking their doubts, a different level of understanding what you're saying. And that skill, however much you practice on standardized patients, will never come.
This is something that has been recognized by simulation experts the world over. And in fact, a lot of them are now arguing against using the term standardized patient because of the very reason to say that our patients are not standardized. So why do you have standardized? So they are now calling them instead of standardized patients, and they are training them to exhibit different aspects of real patient behavior. Of course, you may not be able to cover all the aspects of different patient behavior, but you can certainly cover a lot of them so that the students can better face these patients in the real situation. The point is, it's better to have them as a buffer, if you like, before you go into the real clinical environment, rather than directly practicing with the real patients. The other point you brought up about the fact that simulation does not tailor itself to the learner, I think is a totally erroneous statement. Simulation, in fact, is meant or it should be designed in such a way that it targets learners of different abilities and allows them the ability to practice at different speeds. And in, like, I was working in Singapore, and I'm sure Devnath in anesthesia, they're very, very strong in the US for using simulation. He will agree. You throw open the simulation center to these students to come in at their own time and practice, and people who are not taking longer to get those skills have the opportunity to practice for a longer period of time until they reach the level. So simulation, in fact, mandates it. It says the part of simulation pedagogy is to say that you must not treat all the participants who are coming to you as at the same level, or rather you treat them, you give them the exposure that you feel they will maximum benefit by. So I
Very true. But what I meant was,
yes, sir.
the way that it is embedded in the curriculum in India, that does not leave any scope for
Now, yeah.
differentiating between learners.
So this is a
Because
typical situation where we
that
have
is the
bad
problem.
parameters, sir, and we are blaming the tool. Our regulators have no concept of simulation. The people who have formed the MCI curriculum have no concept of simulation. Now, the National Medical Council also, I do not know what experience they have with simulation. All that we can expect, or we
It's
can
the
hope for,
same set of fellows with a different name, that's all.
and I hope at least that they can have an open mind and bring in experts from different areas where they don't have the expertise to help them formulate curricula using simulation, etc. If that does not happen, it will just remain as lip service, and we will have nice, beautiful simulation centers to showcase to the world. The first place a visitor will be taken when he comes to your institution is a simulation center, and then to the other places, but it will never be used in a good practical way. And that is a tragedy which I find even today in a lot of simulation centers in India. I would much rather have a simulation center which is very meager in terms of its resources, but is being used regularly, rather than a very high tech simulation center which is hardly used at all.
Well said. That's good.
Sir, Dr. Ilango wanted to say something.
Yeah. Yeah.
Right, okay,
Dr. Ilango, please.
you're muted.
Yeah, I have a few things to say regarding this. Regarding the simulation training, I don't understand why there is a difficulty in getting the right fidelity. What I am doing now and what I was doing during all the simulation time, the time spent in the simulation center, is that I used to break down the steps. For vascular anastomosis, it was the corner stitch, then the next to the corner stitch. And each perfection, you can break down the steps and the angle can be learnt very well. It was not possible for any vascular surgeon to do so much of anastomosis like you do in a simulation center. I used to do roughly about 10 in a day, almost like for 1.5 years. So that number you can never get even in a well-rounded transplant program for a single training. I used to finish my clinical work and I used to go to the center, take all the artificial vessels and do whatever I want. The best thing was that when I finish the anastomosis, I can cut the whole thing and see the inside part, how my anastomosis is. This I did not develop because I saw a simulation center. It's just that I was given an opportunity. The initial part of my training in MS General Surgery in 1997, I understood that a good surgical PG will get about hardly 10 or 15 anastomosis, bowel anastomosis at the end of his training. So what I used to do is I got a few pair of socks and I used to use nylon, fishing nylon, and I constantly practiced it so that even when I did the first time, I didn't have any trouble. So that is how I learned. I still practice it that way. The second one is that, yes, obviously I agree it is not learner specific. There is an input from the teacher required, but it is situation specific. I think the student can actually pick up the situation to be trained in. And that is something which I wanted to make. The third point is that simulation always gives the opportunity to make mistakes. So that was something which a virtual trainer actually gives a lot of chances for that. It was a good experience to do that. You cannot do that on a real patient. And like I said, if you do on a tubular structure, you can always have a very good method of self-assessment. I would like to share a screen, but this is regarding a training program which we developed for two aspects. One is to read ROTEM, and the second one is for acute pancreatitis. Can I share that if I have a couple of minutes?
Go ahead, Nilakantan.
While you're doing that, Dr. Lango, I think there was a question in the chat.
Yeah, you can go ahead.
Surgery as simulation. Yes, definitely we can consider simulation because though a cadaver is it's a human being, but having said that, it is not a real patient in any sense of the term, and therefore when you're practicing on cadavers, it is a
seminar में हूँ, मैं तेरे से बाद में बात करूँ, ठीक है?
Those of you who are not asking questions, kindly mute your microphone, please.
Go ahead, Dr. Lango.
Yeah, can you see my screen? This is a Python developed by my son. And I want you to read the one from the patient biodata. This is a nurse administered program. So I'm, sorry, I have to operate this, I suppose. So, okay, it's just sharing that screen.
This is one of the major issues with simulation. No simulation program will ever go according to plan. There will always be some technical features somewhere else.
Yeah, I think this is the Python program. It is. I mean, I'm able to show the screen, but what is important is that it keeps the number of times you can run the program and then see the different scenarios. It's really awesome. Another one I wanted to actually show. I don't know whether I'll be able to share it this way. Is how to learn ROTEM. So we picked up ROTEM. ROTEM is the viscoelastic method for learning coagulation studies. Okay. So that's a small test. It requires that you memorize a few numbers, and you must exactly assess the numbers and find out whether the patient needs an FFP, a cryoprecipitate, a platelet count, or tranexamic acid. So we developed that. Just let me see whether I can pull that up.
So while you're doing that, I'd just like to talk a little bit about the fidelity concept that you were talking about. Certainly, simulation can be very, very close to reality, especially if you use real tissues. For example, if you use animal intestine for anastomosis or a vascular tissue for vascular anastomosis, you'll get a pretty high fidelity. And it is interesting now that we are moving away from the concept of anatomical or fidelity to the what we believe in now as simulation educators is functional fidelity. What that means is whatever simulator you are using need not resemble the real life anatomy at all, but it should be functionally similar to real life. And there was a very good paper on laparoscopic skills, achieving laparoscopic skills through peeling of a clementine. A clementine basically is like a Mosambie. It's with a tough skin which is quite adherent to the underlying cotyledons. Peeling that gives you better laparoscopic skills to translate for laparoscopic cholecystectomy than practicing in a virtual reality laparoscopic cholecystectomy simulator. So that was a landmark article, and now everybody says that functional fidelity, that whatever you're using should resemble the actions you do in real life more than needing anatomical fidelity, that it's shaped like a gallbladder or it is shaped like a specific tissue. So everybody's moving towards this concept of functional fidelity. There are lots of things in simulation which are very good fidelity. At the same time, we haven't achieved good fidelity in a lot of other areas. Go ahead, sir.
Sorry, I'm not able to share it.
Okay.
It comes through Chrome. I'm not able to get that to the sharing screen.
You can
Okay.
on screen share. You can choose to share your browser. There are, like, you can choose to share which screen you want to share. You can choose.
It's not pulling that up.
Sir, Punendu wanted to say something, sir.
Punendu, go
Yeah,
ahead.
before that, you were answering the question about cadaver surgery. Is it simulation? Dinkar?
Yes, I already answered that. I said that I do
Okay.
believe it is simulation, because in no way can you argue that a cadaver is like a real patient in terms of the way they behave or bleed or whatever it is. Though they are human, at the same time they are not human. So cadaver surgery is still comes under simulation. We would consider a cadaver as a simulator.
And
So
somebody wants to know where they can find this curriculum on simulation.
I believe that the best way is to develop your own curriculum according to your local needs.
yeah, correct.
We all know that Medical Council of India has already mandated a simulation curriculum for the whole country for undergraduate education. But I think that is probably not enough. And you'll be aware that in Mahatma Gandhi, in our institution, we have developed a simulation curriculum which goes beyond what the MCI has done. But it's meaningless for me to share that curriculum with somebody else, because everybody's needs are different, and your curriculum should really be based on what you need. You can call in outside experts to help you with the curriculum, but essentially you need to develop that on your own.
What you need and what you have also in terms
Yes.
of, yeah.
One of the problems with simulation, like in so many fields of medicine, is your needs are dictated by what you have. I believe it
Yeah.
should be the other way around. What you need, based upon your curriculum, you should buy your simulators, not that you tailor your curriculum according to the simulators that you have.
So is my screen shared now?
Yes, it is.
Yes.
So this is a Python software, so it is not complete yet. So if you can see that it has got the XMCT, the XMMCF, the XM Lysis 30 numbers, and the FIFTM MCF. So this is a very basic software, but I am not a software engineer. I just put together the algorithm. So my son created this software for me. We are trying to create a web-based interaction. So our aim is to get the nurses and the junior medical staff to learn this protocol by looking at the numbers, because the ROTEM, we are not doing the technical teaching there. We want to teach them the interpretation. So this is one way a person can practice this like 1,000 times in a day. By a couple of days, they will really become experts. So this, I think, is one of the key. In India, what I have seen is surgical curriculum, surgical teaching is extremely principle based. It is not practical at the bedside. So the student who learns very well during his MS days, when he goes back, he finds it difficult to apply everything in his practice. So that gap we have to fill. When I went outside India, they taught the essential things first, like the basic surgical skills, and I learned the principles much later. So it was a different viewpoint, and I combined both the experiences, and it was very helpful for me. So these things I developed for training people with me and under me, so that we get mastery over the subject. This is how I feel. This is one component of simulation probably we are missing. The decision making can be taught very well. You don't need a standardized patient. You can ask the right questions, and based on the answers, this is exactly like how the step 3 USMLE runs. You're given a scenario and you're asked to ask the questions, and the computer keeps on feeding you the answers. It's a good way for the student to learn principles, and even for senior surgeons to revise what is appropriate. And I feel that is one thing which simulation is missing. Simulation entirely treats things as technical aspects. But I feel this this is another important component.
Thank you, Dr. Ilango. I think we'll go on to
again,
Purnendu for brief comments, and then Debu wants to say a few things.
Go ahead, Purnendu.
Purnendu,
Dinker, this is more on, am I audible?
yeah, you are.
This is more on a lighter mood. I just heard Dinker was saying that India is lagging behind very much in simulation, virtual simulation. But I just wanted to make a comment on a lighter sense that way back in 1983, those who did not have the pleasure of working in Unit 1, during our ward round, we literally had virtual simulation of how things will go. We could visualize. The tongue will be taken out from here and the forehead will come, the mandible will go, and then the pectoralis major will go there. And Dinker, your simulation is only for the surgery. Our simulation was, we could visualize the post-operative period. It was a complete simulation of the total operative procedure, including the post-operative period. So I thought I will bring this, like we had also planning of the surgical steps, and a large number of people who went through those 3 years know that how we could take the ribs and put it into different area, and we could literally visualize, even including my thesis, phallus reconstruction with a rib inside. These were all virtually simulated. I don't want to increase this, just wanted to make the situation light. I don't know whether it is coronavirus which has affected my brain. The last part of Ilango's total simulation went above my head. Sorry about that. But Dinker, I was remembering the time when you came and stayed with us and we were trying to pick up laparoscopy. Do you remember the days?
Yes, I do.
Yeah, that was nice. Okay.
I had a very
Okay, Debu, come.
Thank you so much for inviting me to the seminar. I just want to go on the record saying that anesthesiologists make surgeons' life a lot easier, even though we are primarily there to take care of patients. I just have a couple of comments about simulation and medical education. And as an anesthesiologist, this is something that is used extensively in our field, not only to practice like rare scenarios like malignant hypothermia or anaphylaxis, things that we don't routinely see. And so we use simulation quite a bit. The only comments I would like to make is, one is that, I think Dinker mentioned high fidelity versus low fidelity. Obviously, using high fidelity simulation is very good, but it's also very labor intensive to get people out of the ORs, to get people to get out of their busy clinical schedule. So there's a lot of push to use low fidelity simulation. And there are several things like using cognitive aids for arrest cases and like emergencies. And so what we use very frequently in the operating theaters is actually these cognitive aids. We all have apps on our phones that, we're able to pull out, the different steps of managing, a complication. So every time a child has a laryngospasm or there's an arrest in the operating room, like somebody pulls out their phone and goes through the cognitive aids. And so that, using that, I think is a great opportunity for low fidelity simulation. And the second piece I wanted to talk about is the importance of making this multidisciplinary, because we all think about using simulation for anesthesia, for surgery, but I think there's a huge value in doing this together, because as Dinker mentioned, it's all, most of the times it's communication problems that cause errors. And so practicing closed loop communication, and as he mentioned, the crew resource management training, et cetera, is critical. So just using closed loop, like if somebody asks you to place an IV or to give a drug, you repeat back that you're giving the medication, you're placing the IV. And so, practicing this as a team rather than having our own different silos, I think is really important. So every time we have a simulation session, there is a surgical resident, there's an anesthesiology resident, there are nurses, there are techs. So doing this together I think is really important, and not doing it in silos, because communication, as you know, is the major problem most of the times.
You'll be
Thanks,
happy to
Debu.
know,
Thanks a lot.
in our institution also, most of the simulations we are running it in a team of anesthetists and surgeons mix, and we are now trying to get in nurses as well.
Actually, I got sold into simulation, like Dinker said, because I experienced it. I just signed up for a simulation workshop, and it was on obstetric anesthesia. So we had these, simulated a postpartum hemorrhage. And so there was everybody there. There was an anesthetist, there was our two obstetricians. You have to communicate with the blood bank, have which drugs are kept, what is to be diluted, and all that. So once you actually experience, like Dinka said, I don't see many senior people attending the simulation workshops. So most of the time, I'm the only older person. All the others are kids, but I think it's very essential that senior people should attend this simulation workshop to, really understand how much it can actually be used, because you can do the same thing without even a mannequin. Many of the things for teamwork and communication, you can do it, like Dave said, you don't even need a mannequin for it. You just need to put the process in place, and everyone should know what they're doing. And I think that anyone can do. You don't need a big posh sim lab to do that. Having said that, the basic skills, like Dr. Ananthakrishnan mentioned, because there are less patients and more students, for some things obviously it is going to help, because everyone has to learn to put in an IV line. So like Ilango said, you can go to the sim lab and keep putting IV lines from neonate to a geriatric patient any number of times you want. But the minus side of that is the students may not do it. So like Dinker said, there has to be a curriculum, which means that everyone has to do it. There's no point having this lab which hardly anyone visits. It's all people who have the facility don't use it, and those who don't have are, sort of really wanting to have it. So I think there has to be a mix as to, person like Ilongo, somebody like Ilongo may go and do it all the time, but someone else may not do it at all. So that has to be, that's why you need the curriculum, like Dinker and Prof.Ananthakrishnan said.
Vidya, I don't see any other questions, so it's back to you or Patta. Because nothing is there in the chat box.
If does anyone else want to say anything? We have a few minutes. Dinker, any final words?
Can I say something? Can I say something?
Sure.
Welcome, Geeta.
Yeah, okay. Thank you, Dinker. Many of you might know Dinker is my batchmate, and I'm so happy that he gave this talk. See, about 3 years back, Dinker had come to AIIMS Bhubaneswar, and he conducted a workshop with his team from Singapore. And it was really a 3-day workshop, which many of our faculty members loved it. And as we showed that, and we have only now actually procured our this high fidelity simulator, and I think they are in the process of setting it up. But also what we had done is we have got the College of Nursing. They had put up a proposal to the ministry to set up a nodal center for simulation for this region. Because I feel things like that, because if you can train people for a region, from the government, from the other areas of Odisha, because that will be more useful than individual institutions having and not being used, like what Vidya said just before. The other thing is, what I also want to say is that a little bit about what all of you seem to say, even Debu said, because now what is happening is people are not able to connect with each other, and it's leading to a lot of problems in different areas. Somebody just says something in an email, and then everyone says, how can this person is a nurse, how can a nurse write like this to a doctor, and things like that. Because see, we people who trained in JIPMER, we had classes taken, Dinker will remember, we used to have classes taken by the nurses, how to make beds and how to give a newborn baby a bath, and
Everything was taken by nursing, if you remember.
that was taken by nursing. So we never, we always, and we learned how to give IV fluid, IV injections and all from the nurses. So we never felt that, that we are, at the top of this hierarchy and they are somewhere below and all that. So this is one thing I have a problem. As you say, if we train them in teams with various, from various doctors, nurses, technicians, everyone come together, that would be useful. Otherwise, I'm seeing that there is a lot of, this hierarchy, and they simply don't seem to be able to trust each other. So that was just the comment I wanted to make, Dinker.
No,
But thank
That's
you.
the
It was a very good
greatest
talk.
problem we are having in getting multi-source feedback from healthcare workers about the doctors in training, particularly postgraduates. The reluctance on both sides for them to give and to discuss it with the concerned postgraduate resident anonymously. So that hierarchy has to be destroyed, but it's there. It's grounded in our culture for a long time. So it will take a lot of efforts to make everybody feel equal partners in the team.
One comment I just wanted to make, taking off from what Geeta just said. One of the important uses of simulation, which I have not touched upon, is process testing. That means testing how things actually go on in the clinical area of the hospital using in situ simulation. In Singapore, we had this problem, which we have faced in India as well, where the emergency team will see a trauma patient and then they will call the orthopods or the trauma team from somewhere else. And the first thing that used to happen was a big shouting match between them. You did not do this, you did this. Why did you not take an X-ray before you called me? Scene that was very familiar to me. So what we did was we ran simulated trauma scenarios in the ED, where the ED physicians first came in, then we called in the surgeons, we called in the orthopedics as required. And initially when the trauma team training was going on, the same issues cropped up. Then after several rounds of debriefing and learning, now the whole team became so cohesive, and there was a practical improvement in trauma care on the ground as a result of that. So you rightly pointed out, I think simulation not only helps in training people, but as you know, same thing in conferences, when you come to know each other, you are much more forgiving of others' faults and you're much more appreciative of their strengths.
RK, would you like to say something? Can't hear you.
You're muted, I think, but I can't hear you.
No, we can't hear you. I think your audio is on some other device.
You have Dr. Hadke, Noor Topno, Dr. Smile. I see a lot of people familiar names.
Noor Topno is there. I see his name.
Yes. Dr. Hadke also.
Hadke, you want to say anything?
Perhaps everyone's here. He started sharing.
Yeah, Hadke is, yeah.
We also have some students, so if they want to give their perspective, if they've gone through a simulation, that would also be nice.
Yeah, from our college, I see a couple of names.
And I think they have had experience with simulation as well.
Meenal and Karishma and all that. Hadke, you want to say something?
I think
No.
he's accidentally pressed his share screen.
Okay, then can we get comments from some of our postgraduate residents?
Dr. Hadke, can you stop your screen share, please?
Yeah. Karishma, are you still there?
Shruti, I can see.
Shruti or Meenal, they're all gone, I think.
They've learned from the master. So
No, Vidya, the greatest problem we are having is these virtual classes have got only virtual presence. They just switch on their computers And then they come back for saying bye-bye.
I must confess that is what I did at 5 p.m. today, sir.
Oh my God. In spite of the mandate?
Because of the mandate.
So, if no one has to say anything, I'd like to thank all of you for joining us, and big thank you to AK sir and Dinka for keeping the discussion going, and hope more and more people will get interested in simulation and use it in a really, the best way to improve both learning and patient care. Thank you everyone for joining us, and we'll meet again next Thursday.
Thank you, Vidya. Thank you, Patta, and thanks everyone else. Particularly those faces that I'm seeing after so long.